Good morning, everyone. Welcome back to Cardi-OH Tackling Type 2 Diabetes Clinic. I'm Jessie Lewis, the clinic coordinator. If you could, please be sure to chat your name and your practice name into the chat feature so that we can record attendance. And then as well, if your full name isn't showing in the participant list, you can change that as well. If you hover over your name, select the More button and then click Rename. You can type text into the text field there. Just be sure to keep yourselves on mute unless you're speaking, and then feel free to comment or ask questions in the chat feature at any time during the session. So I'm going to go ahead and turn it over to our facilitator, Dr. Dungan.
Hi, good morning, everyone. I'm Kathleen Dungan, endocrinologist at OSU, and I would like to also introduce the rest of our hub team for today. Gautam, I believe you're on. Would you like to introduce yourself quickly?
Sure, Kathleen. I'm Gautam Rao. I'm the chair of family medicine at Case Western and the director of the ECHO program.
And our didactic presenters today are Sharon Watts and Liz Beverly. Sharon and Liz, would you like to introduce yourselves?
Sure, thanks, Kathleen. So I'm Sharon Watts. I'm a nurse practitioner and certified diabetes educator at the VA for the past 20 years, working on diabetes improvement projects.
Good morning, everyone. I'm Liz Beverly. I am a behavioral diabetes researcher at Ohio University Heritage College of Osteopathic Medicine.
This is the structure of our clinic. So we'll have a 25-minute didactic presentation followed by Q&A. And during that Q&A, again, I'll just kindly encourage everyone, if you have a camera, to please turn that video camera on so we can have a great collaborative discussion. And you can either use the chat feature, but even better, if you can unmute your microphone and ask us questions in person, we'd love that. And that'll be followed by our case study presentation, about 25 minutes or so, with the same kind of discussion format as with the didactic. And then we'll have our brief wrap up. And these are our disclosures. These have been shared with you already this week. And without further ado, I'd like to get started on our didactic, Advanced Diabetes Care Models. And this will be given by Sharon Watts and Liz Beverly. Go ahead.
Thanks, Kathleen. I was trying to use the remote control to advance and I was too premature, but I want to thank all of you for coming today and thank the organizers for asking Liz and I both to speak. So quality improvement in diabetes is near and dear to my soul. I've been doing this for 20 years at the VA. We've got great resources, and I want to share with you what kinds of things work. So we were given several objectives to cover in this talk. Talking about teams, I was asked to speak about group visits, shared decision-making, and then joy at work, which is fun for all of us. So it's an eclectic assortment of objectives, but we're gonna touch on every one of them and see what you find that you might benefit from. So when we talk about teams for diabetes, let's face it, primary care visits, you're lucky if you get 30 minutes. These visits were fashioned 90 years ago when we didn't have such advanced chronic disease and multiple comorbid conditions. People would come in for a sprained ankle 90 years ago, and sure, you can handle that well in 20 or 30 minutes. But our patients with diabetes and chronic diabetes, so I work in endocrine, and I see all the patients who can't be handled in primary care. So anyways, I still get 30 minutes for my patients as well in endocrine. So you really have to think outside the box to be able to help patients with diabetes. And so that's why I'm really encouraging team involvement. And let me share the evidence with this team involvement. First off, think nutrition. Referring to nutrition, and I'm not talking run-of-the-mill dietitian, I'm talking certified diabetes educator nutritionist, because it's a different type of nutrition. For years, I've had patients say to me, no, Sharon, I don't want to go see the dietitian. They're just going to tell me to lose weight. And that's not what my dietitians do with my patients. I mean, sure, I'd love them to lose weight, most of them, but I'm referring for consistent carb diets to keep, and I tell them I want to keep you safe so you don't go too low or too high. They also talk about Mediterranean diet. There's plenty of evidence on that. In the VA and during this past year with COVID, there's a lot of food insecurity issues. So people with diabetes who have food insecurity, and I know in our audience, you have patients as well like this, there's more hypoglycemia with food insecurity. You know, 2 simple screening questions our dietitians give them. Do you find that by the end of the month, you've run out of food? And I forget the other one, but it's very similar. So we have things that we can do to help with our patients with food insecurity. And the last thing is that the dietitians I refer my patients to always go over hypoglycemia. So that's an extra layer of protection for you as the provider, because I'm sure you don't have the same kinds of worries that I have of patients drinking a 12-pack on the day the Browns are playing and they have diabetes and taking insulin, right, and risking hypoglycemia. But so there's a lot of education, and the evidence shows you can lower A1C 1 to 2% with medical nutrition therapy. Again, it's different than run-of-the-mill referral to a dietitian. This is a certified diabetes educator dietitian. So good evidence, start there when you're thinking of involving the team. So diabetes self-management, education, and support. These are certified, recognized programs where from 2 organizing bodies, the American Association of Diabetes Educators or the American Diabetes Association, recognizes these programs as certified to be able to teach diabetes. And there is plenty of evidence that patients going to these classes can lower their A1C 0.5 to 1%. They give them self-management strategies, and it's not just A1C lowering. You'll see an additional slide later. Patients that go to these classes have less ER visits, less hospital admissions. I mean, those are dollar signs for your hospital administrators to see. But it's an added layer of protection for you because there's a lot of information to handle diabetes. People do all kinds of crazy things. I called a patient yesterday and he was taking Novolog insulin 4 times a day. He said he was discharged from the hospital and they told him to stop his Lantus. So taking 20 of aspart at bedtime. I mean, you just hear crazy things. So your educators can also ferret out these crazy things that are happening with our patients at home. So anyways, for us at the VA, a certified program is a win-win. We can get third-party reimbursement from insurance. And, even in a city like Cleveland with low income, that's more than enough to pay a dietitian's salary to teach this class that we pull in. The classes are interactive and they're a way to support each other during diabetes journey. So this was a paper that I put together of the benefits of diabetes. It was published last month in the Journal of Nurse Practitioners. And seriously, I was surprised at finding this evidence. Even I knew a lot of it, but decreasing diabetes distress, all-cause mortality, the hypoglycemia is really what you as providers are happy to hear that it's decreasing and adding an extra layer of protection for you. Those are the diabetes classes, healthy coping. Patients like the diabetes classes. So our patient satisfaction is very high with it. And administrators like to hear that as well. So more on the medical nutrition therapy, it's just a win-win if you can get them to go. At the VA, with my patients with type 1, they have to see the dietitian in order to get a continuous glucose monitor. Because they need to know consistent carbs. The dietitians teach them about the monitors for me. So it's an extra carrot, incentive to go, but it really works. And we get some great results, even from patients who say, oh, I've seen dietitians all my life, So consider this for your practice. How can you refer out? And from previous cohort, I know I had talked to some practices that were trying to do their teaching on site. And it's just so hard, and you don't have the resources that these certified programs have, or advanced nutrition folks have. This was just one small study I found, but I thought it was good. And we have previous literature on that. It's just that having multiple touch points for your patient, touch points being a case manager, diabetes education, medical nutrition therapy, increases adherence in the long run, increases med adherence, and increases and improves outcomes. We know this for years and years. With something as complicated as diabetes, just having someone pick up the phone. In this study, they were case managers, and it was a supplement to primary care. And they received these intervention 30-minute in-person sessions, baseline 6 weeks and 12 weeks by these care managers by phone contact, which we can do during COVID. And even the 37% of the sample that was adherent, they were adherent 72% of the time with their meds at baseline, but that bumped up to 100% after the intervention. For those people, 29% significantly increased their adherence from low to high. They were only 30% adherent at baseline, and went up to 80% by the end of the study. So again, think of multiple touch points for your patient. You can't do it all as the primary care provider, but there's a whole slew of literature out there about nurse case managers, pharmacists, seeing patients in between. Our British colleagues in the National Health Service have a lot of literature on nurses, and they send their clinical nurse specialists for a year of training in diabetes. And then they have them follow up on all their patients with diabetes. So around the world, there's a lot of literature about this. The US is a little slow on the uptake in this, but the evidence is clear and good. Use your teams to help augment your diabetes care. I'm going to switch gears and talk a little bit about shared medical appointments. So at the VA, we were asked to create shared medical appointments. I think it was back in 2005. The idea was increase efficiency of clinic, give patients support, bring them together, do a little bit of training and intervention, and try to improve diabetes care. And at the time, I was asked to implement this in primary care. And a colleague of mine said, Sharon, you're nuts. If you're trying to get patients over A1C over 9 to improve, it's not going to happen. I said, well, let's see what happens. So several publications later, we do have improvement for these patients. And here is the manual that we created. It should be accessible outside. We have a very strong VA firewall, but this is outside the firewall. So you should be able to access our manual. And so if you go to the next slide, Rich, I'll tell you a little bit about our shared medical appointments. Unfortunately, we're not doing them now during COVID, but we did find that they improved quality of care, very high patient satisfaction, increased access. If I had someone with an A1C of 14, I could get them into the clinic that week. We had decreased wait times. We definitely had improved A1C outcome measures. We used it minimized, I'm not sure about minimized costs because we didn't look at that, or the VA, but we did utilize all healthcare team members to their maximum capacity. So our shared medical appointments were led by our health psychologist. So I did spend some time talking about certified diabetes educator education programs and medical nutrition therapy. The other key member in your team is your health psychologist. So people who have A1Cs over 9 consistently, there's some kind of barriers to care, and primary care providers or endocrinology, we can't get their A1C down unless we help those barriers to care. There's all kinds of things, substance abuse, pain. I do a fair amount of referrals for health psychology, people overusing their insulin, and I need to get some help on what that is, or all kinds of things. So that's the third tripod of the team, getting your diabetes educators, your medical nutrition therapy, and your psychologist involved in patient care when necessary. Our shared medical appointments are also co-led by the dietitian. Dietitian and the health psychologist are the two hardest people for me to get my patients to go to. So by bringing them into a shared medical appointment, we kind of do a backdoor way of getting them exposed to nutrition and health psychology when needed. So it's a warm handoff, if you will. They already meet these people in shared medical appointment, and they find out they're not terrible people. And yes, sure, I'll talk to them after the shared medical appointment one-on-one. I ask them when I see them. So we'll go to the next slide. The benefits of these shared medical appointments is the teamwork. So it has been fantastic. I find myself using the phrases that I hear our health psychologists say all the time, and that's great for me because I don't have that background in training. You learn, and we all learn, we all improve. I have someone, we have a pharmacist in our shared medical appointment. So when I have a question, I can just shoot off an email to her, and it's just wonderful camaraderie. We work well together. It's a supportive environment for not only staff, but the patients. The patients love sitting in a group and talking about their diabetes and the barriers to improving diabetes and to, eating and everything else. So there's a sense of additional support for primary care providers. They are best, they refer everyone to the shared medical appointment. Obviously, if there's severe mental illness, they don't refer them to the shared medical appointment. But I will tell you, the patients who come in grumbling and complaining, I don't need to be at this shared medical appointment, they are the hardest people to get out of the shared medical appointment once their diabetes is fixed. They love the group support, and they love just having more one-on-one time with providers. It's just a funny phenomenon, but that's how it is. They gain a sense of control. There's improved health. We definitely have great patient satisfaction scores from our shared medical appointment. And that manual that I said you can have access to outside the VA firewall has everything in there because we got calls from all over the nation. Well, how do you start a shared medical appointment? So I was getting tired of the calls. And so we've updated that manual so that you can just take that manual and create your own shared medical appointment. Everything we could think of for starting shared medical appointment. And so, you know, we would find when people would come to visit, there was mixed messages about what is a shared medical appointment. What's the difference between that? And, you know, we have certified programs for diabetes education. We do not want to reinvent the wheel. We do not bring our patients for education during the shared medical appointment. We make a referral to the diabetes class if they need more information. The shared medical appointment is for people whose A1C, we use a registry and we populate A1Cs over 9, they automatically get an appointment into our SMA, or they get referral from their primary care provider. But the purpose of the shared medical appointment and the discussion, we do a little bit of safety discussion, and that was what I was insistent upon, because we have residents, rotating residents, and I had to make sure that hypoglycemia was always discussed. So that is always discussed, but the rest is open discussion about barriers to care. And, you know, so a little bit, if patients want to talk about nutrition, they talk about that. They want to talk about meds. We usually hand out pill boxes to help with med adherence. So it is not a support group only, because we have medical providers who pull the patients out of clinic after about, you know, a 30-minute discussion and titrate their meds, renew their meds, whatever. So again, it's not diabetes education class. We have a class for them, which is separate, and we often refer them to that as well. None of these approaches will work if we don't have a shared approach. So this is Agency for Healthcare Research and Quality, and they have quite a bit of research behind their approach. And any chronic disease, you know, there's a lot of patient onus of responsibility on the patient to take their insulin, whatever, you know, to eat everything. It's a complicated disease, and they have to be willing to take responsibility. So when I see a patient, you know, I explain, the idea is, you know, you should ask, may I share some, you know, information with you about diabetes? Get their permission first, or treatment options or whatever. And then explore different options, medications, diet, whatever you have in mind as a provider. Ask what are their values and preferences. I remember Institute for Healthcare Improvement years ago, you know, telling us to ask what's important to you. And I do put that in my note, what's important to you. Reach a decision together and evaluate your decision later on. So I really get patients' involvement in what treatment options are there. And then I'll ask them on a scale of 1 to 10, how likely do you think you're going to be able to get rid of your 2 liters of soda a day? This is a real patient 2 weeks or about 2 months ago. And, you know, he said maybe 8 to 10. He was very likely he could get rid of it. You know, and so if they say 8, well, how come you're an 8 and not a 6? So you get their motivation. You elicit their motivation, their values for changing behavior. So that's the Agency for Healthcare and Research Share approach. This is very popular in Canada. There's a lot of literature on it, and literature that, you know, and providers will say, gee, that takes a lot of time. I'm very quick because I have 30-minute appointments when I've learned to do this well, but patients often say to me, gee, you really spend time talking to me. Well, I spend the same 30 minutes everyone else does. But I try and get their input, which is important. So next slide. And this is probably the most fun. The last slide is, gee, how do we do all this and have joy at work? So work satisfaction is important. It's retention for employees, but not only important for employees, it affects patient safety and care and organizational performance. If our employees are not happy, there's more sick time, there's more everything, and patients aren't doing as well. So as organizations and as employees, we need joy at work. So I have, this is a particular interest of mine, and I've looked into the literature about it. So some of the things necessary for joy at work for employees include physical safety. And gee, that was a tough one during COVID because I was still going in to see patients without the vaccine. Having a sense of purpose and meaning in your job, having some sense of choice and autonomy in your work, and then camaraderie. I've been really grateful to have good colleagues that I work with at the VA and doing QI projects across all different disciplines. But as managers out there, having choice and autonomy and a sense of purpose, I think we all have a sense of purpose as healthcare providers. And I will just end before I give it over to Liz with an interesting study I found about diabetes healthcare providers who experience diabetes distress, just like the diabetes distress scale that our patients take. And boy, I've been there because, you have patients who have a lack of treatment adherence. You worry about their kidneys going south. You worry, you feel overwhelmed by the social needs of these patients. And I'm grateful that the VA has a safety net for the social needs of our patients because, man, they're wide. And yesterday I had a guy with type 1 diabetes and no electricity. Couldn't upload his CGM for me because his computer has no electricity. These are tough times. And the diabetes, that they administered the same test to providers and found out that patients take to, it's a validated test of diabetes distress. And they found out providers, nurses, dietitians, we all experience diabetes distress going through these journeys with our patients. So we've got to work at ways to cultivate joy at work. And QI projects have been shown to improve joy at work. Obviously, self-care activities are important. And then I think I'll leave it to Liz to wrap it up.
Thank you, Sharon. That was an excellent presentation. My role is to put an exclamation point on what you just presented. So I have this one slide where we're going to focus on some of the interventions in the QI work that you can really emphasize joy at work. So you can see here with some interventions that have been showing promise in promoting joy. Some examples are appreciative inquiry, organizational change, and meaning of work. And I think reflection on this past year, for many of us, especially as we approach a year with the pandemic, I think a lot of us maybe even self-reflect about the joy of work and where we're at with joy of work. So thinking about appreciative inquiry, what is that? So appreciative inquiry, what's different about that than the way we approach a normal work is appreciative inquiry focuses on what is best, and it's using a platform to build future direction. So it's focusing on the positive and working to strive for what you already have as a strength and focusing on the strengths to build more. It's opposed to kind of how we, I would say, as an American culture, focus on things. So when you think, sorry, that's my dog. When you think about how we focus on medicine, a lot of medicine is focused on the disease or the illness and identifying the problem, the differential. And then how we address things even in everyday life. We're trying to identify gaps or problems with society and then trying to fix the problem. And a lot of times, that's sometimes what we do with diabetes. Even with diabetes education, we're teaching problem-solving skills. So we're trying to focus on the problem of what's going on. And appreciative inquiry is kind of that cognitive reframing of, instead of focusing on the problem, and we excel as Americans on focusing on the problems and identifying what's wrong with everything. appreciative inquiry says, hey, let's focus on what's going really well and let's go from there. And so the approach for appreciative inquiry is called the 4D process, and that's where you have discovery. So you're discovering what is going great with your organization. Then it's dreaming. How do we go from here? What do you visualize would be the ideal situation, or what else do you want to see with your organization or with your team? Then it's focusing on design, which is then how do you get there? So you're planning. And then the destiny is kind of implementing those strategies to get there. So there's a movement towards focusing on the appreciative inquiry. In terms of organizational change, if you look at the burnout literature says, there are small interventions you can do as an individual, but that doesn't necessarily sustain joy in work. What we really need is the organizational change. So some of the things for organizational change I've listed here: limiting work hours, having flexible work arrangements, providing leadership training and communication skills, really focusing on teamwork and relationships. So these are things that the organization can do. And of course, you would play as an individual a role in these things. So if you find yourself in an administrative role or being a leader at your organization, focusing on these things can have a very powerful impact in promoting joy in work. And then one of the other things is, I think, especially now, if you've been reading the lay literature as well as the medical literature, burnout is a huge problem due to COVID. People have been working nonstop based off what Sharon just said, needing the safety at work, and how so many people have been working without that safety net and feeling that they were safe at work for so long. Many individuals may be struggling with how they've been coping and how they feel towards work, but that might have advanced to an emotional health issue or a mental health illness. And so it's really important that you're in a safe environment where your team tells you that it's okay to seek help if you need it. We should all feel comfortable. I think the stigma with mental illness has changed a lot in the past decade. And we also really need to focus that and encourage providers to seek help when they need it. And then, of course, if you are a leader or a director at your organization, there are ways to survey your employees and your teammates to use wellness surveys to kind of get feedback for how they're doing, and to take that information and then to make changes based off of their feedback.
Great. Thank you so much, Sharon and Liz, for that really great, thorough presentation. We already have a chat message. And again, just a gentle reminder, if you can turn on your video for our discussion here. The first question is from Kriti Aurora. Are you aware of any telehealth shared medical visit resources? And yeah, I was going to ask that too, but as well, are there any options for non-VA patients to participate in these kinds of programs?
Yeah, so I did respond in the chat. Unfortunately, VA can only see VA patients. However, we are responding to our fourth mission and vaccinating non-VA patients right now. We are currently not doing our shared medical appointments. We suspended them during COVID, but there are sites across the VA who are doing virtual shared medical appointments. It's a little tough holding the conversation together. It's difficult in a room full of patients getting sidebar conversation. You have to have skilled providers to run those group sessions. But I did put that shared medical appointment manual, and access is to it. Everything you want to know about shared medical appointments, I would look at that manual if you'd like to start your own and try telehealth.
So Sharon, there's another question about the cost benefit analysis. Are you aware of any kinds of analyses that have been done?
You know, that is always the question that comes up. I think the cost benefit, I haven't seen people analyzing the cost benefit to keeping A1Cs at 11 and 12 versus having another provider in a shared medical appointment. You know, we know in the long term, dialysis is not cheap. And so I would like to see those cost benefit studies. We're always going to have these patients who have a hard time keeping it together. And, we have patients in the past who would come back every 6 months to our shared medical appointment if they needed to. But no, I don't have cost benefit. It is tough and I get it. And for those sites asking, I always tell sites, you'd be surprised, getting another provider in the clinic might be hard, but you usually have dietitians who want to participate. You might have a nurse CDE, a pharmacist, so think outside the box when you're trying to get your bodies into the shared medical appointment to help you.
Thank
So,
you so much.
Kathleen, I just had a comment along those lines. I think there's, as Sharon's saying, there's a lot of unresolved questions with respect to shared medical appointments. The right comparison, of course, is shared versus individual medical appointments. And I do believe there is some literature around that. My bigger issue is that the types of people who participate in a lot of these extended interventions, whether it's diabetes, self-management education, group visits, and Jim and I find this with the Fitter Me program as well, is that they do not represent the undifferentiated population of patients with diabetes. They are especially highly motivated, self-selected, and of course they derive a benefit. So I think the real thing would be to say, hey, we provide diabetes care through shared medical appointments. That's what we do here. And you may be not randomized per se, but that's what we do, or that's what we're going to do for a while, and compare that to the more individualized approach. I think that would give us some meaningful answers, because I agree with Sharon. We've got some questions here, and there's nothing more disappointing than investing a lot of resources in shared medical appointments up front, and then people don't show up, which is really, really discouraging.
Right. Well, I think we do need to move on to our case. If we could move that, put that up on the screen. It should be just a few days. I've seen maybe the effects linger as long as a week or so. But that's a really great question. How does the group manage steroids and steroid injections in particular?
We were talking about cost benefit. So this poor lady who is very arthritic, I understand, Mary, and probably has some mobility issues. I think the benefits of a steroid injection outweigh the transient worsening of her glucose control, at least if it makes her a bit more mobile. Maybe she's able to buy some healthier food, get a little exercise. So I don't usually think of diabetes as a contraindication.
And one of the things that I think that you were hinting at is to really figure out, okay, is there a way to stabilize her so that you don't get her to a point where she might have a few days of severe hyperglycemia? And so it seems like you've got two different problems. Maybe you've got a few days of hyperglycemia superimposed on her chronic hyperglycemia. And so the first thing would be to take a look at her target. At her age, I think it would be plenty reasonable to loosen that target to maybe 8% or so, particularly if you're going to be considering insulin. And at that A1C, that probably would be what I would think about next.
This is Karen. I'm just wondering if during the hyperglycemic episodes, because of the steroids, with the support of her granddaughter or whoever's helping her, could she maybe use a correction scale and check a little more frequently on the blood sugars and maybe correct for the highs until blood sugars come back down while she's using the steroids?
That is the approach currently, is a sliding scale, which we just taught her.
Yeah, so what I'm thinking of is you might need a basal insulin or GLP-1 because she's got pretty high kind of just chronic hyperglycemia.
Has she been on a basal insulin, Mary, in the past? Atlantis or anything?
Not recently. And I think there was a gap between June and February, when I checked her A1C, just, I guess, COVID, I'll blame COVID for everything. But so that was kind of surprising how high it was.
I'm wondering, this is Sharon, if she ran out of medication for a while, something happened. She started eating more. Her BMI, you said she's at like 189 pounds?
Yeah.
Yeah.
186, but yeah. And she's fluctuated like that for years. So her BMI is 29.
Okay. Yeah.
But yeah.
By 12 years of diabetes, you know, I suspect she ran out of meds for a while when I see an A1C like that, or started drinking soda all day long, or who knows what. But by 12 years of diabetes, like Kathleen said, she either needs basal insulin or a GLP-1, depending on finances.
And this is Joshua. I think great comments all around. And I think that this is one of these situations where potentially a combined basal insulin GLP-1 combo, you know, might work nicely for someone like this, given the advanced age, et cetera. My other very quick comment is that, you know, with these injections, most of them are like triamcinolone type injections. And there are different formulations where there's like an extended release. You know, there's different formulations of it. There was a paper back in 2018, I think the guy's name was Stephen Russell, where they compared a couple of the formulations, and some of the formulations actually lead to kind of less increase in glucose. And so I know some of the rheumatologists here have been, you know, asking, and I can't remember the brand name. There's two different brand names, but there's one that's a little bit better. And so that might be a consideration for the next injection that she gets. And then my last question, and this is definitely a question, is, you know, when we think about getting these injections, it's, you know, I 100% agree that, you know, it can be 4, 5, 6, you know, 7 days of elevated sugars. And then most people come back to normal. But I know in clinical practice, like there definitely are people who don't come back to normal. And like this is their transition from like oral hypoglycemics over to insulin. And I'm wondering if they were just on that point in the curve where this was just kind of the final insult, and now they need, you know, insulin therapy. And I just wonder if other providers have seen that.
I feel I have, and that's why I presented her. And I was surprised at the beginning where the injections were considered that transient. And maybe it is, like you said, at some point in the disease process, they leave their baseline and now are insulin dependent. And I believe maybe that's where she is. And that is a good thought, as far as the basal and maybe a GLP-1.
I would say that I do see people that have been diabetic for a while, just and very well controlled, and sometimes I can identify something like a steroid injection, and sometimes I can't, but they just have an abrupt change and have to go on insulin or multiple other medications. So that happens, and I'd be curious to know if anybody's seen that in the literature, especially with a inciting event like a steroid injection or something.
I haven't seen too many acute inciting events, but I think, you know, there is the phenomenon, sort of islet cell exhaustion or depletion that takes place over time. So I wonder if, and she's 84, so she's probably had diabetes for a number of years. I wonder if that's, I mean, diabetes is a progressive disease. I don't think it gets better. So I wonder if that's just what's going on with her.
Yeah, and COVID has really done a number on patients with diabetes in general. You know, who knows what else might be going on that's, you know, changed just abruptly in people's lives. There is a good amount of literature on steroids and diabetes, higher risk of diabetes down the road. There isn't quite as much on steroid injections. Most of it's more, you know, chronic oral steroids or you know, higher dose steroids. So there's also, I just wanted to comment on your question about fructosamine. So fructosamine, it is, for those of you who aren't familiar with it, it's basically just an assay that measures the amount of glycosylation of serum proteins. So it's a very kind of non-specific marker but it's a marker, a short-term marker of overall glucose control. And it can be considered an alternative for A1C when A1C is not reliable. It has about, instead of kind of a 3-month window that we think of for A1C, the window is about 2 weeks. And it can be useful for assessing short-term changes in glucose control. In particular, some of the models where it has been used successfully is in the pre-op situation where you're trying to get somebody ready for a surgery and you don't have 3 months to make sure that their A1C has normalized. Now, you can also use, just standard self-monitored glucoses or CGM, things like that. But this would be something where you might consider for people who maybe aren't on oral age or who aren't on insulin therapies or monitoring frequently. The one thing that you have to make sure that you're aware of is this patient have any evidence of malnutrition? So if they've got hypoalbuminemia, it's not going to be as reliable. There are some ways that you can probably correct for that. But as long as their albumin level, I think your total protein's normal. There are some questions as to whether it might be, less accurate in patients with advanced kidney disease. But in her case, it might be reasonable to use. And if I have somebody who has had recent changes in their glucose control, I might order a fructosamine level. It's actually a pretty cheap test. It does take a few days to come back though. And, there are other assays like glycated albumin that do kind of correct for that issue with hypoalbuminemia. But I've definitely used the assays. Has anyone else used fructosamine?
This is Sharon. I do use it when I have patients who are either high or low glycators. Their A1C just does not match up with their blood sugar values. So, and you can Google, what a fructosamine would be in an A1C. A fructosamine value would be equivalent to with an A1C. But I don't use it often, but I just, but I like the idea, Kathleen, about surgery, because we get a lot of referrals for surgery and getting their blood sugars down. And, these surgeons are adamant they want an A1C and it's going to take 3 months, to show them that it's improved.
This is Joshua. Great conversation. I used to use them more, but with the professional CGM, I find myself using a professional CGM more than I do the fructosamine now, because I can put that on them. It takes a few days for the fructosamine to come back anyway, so it's only about a maybe 6 or 7 day difference between having fructosamine or having the professional CGM. And that way I can also look at other patterns. I not only know if they're high or low, I can see kind of what's going on with them as well.
Great idea, Joshua. Thanks. Giving me food for thought.
Mm-hmm. Yeah, there was another comment in the chat from Kay Hoops. I have some patients who receive an injection every 6 months. And so we'll use that previous experience to trend how long their sugars are elevated, increase the basal insulin briefly over this time period, and prepare them for the eventual increase in glucose. This similar kind of scenario in patients who are getting steroids with their chemotherapy. So you sort of learn with each cycle, how much extra insulin they need. And they're usually pretty motivated, even though they're overall, just really sick. And so you can kind of see, okay, well, 10% increase didn't do it. Maybe you need a 20% increase to cover that, those steroids. And of course, 20% is still very small beans as far as steroid goes.
Thank you.
Okay, well, if there are any other comments, I just wanted to maybe circle back if we have maybe anything else anyone wants to talk about as far as the didactic presentation. There's a lot of great discussion in the chat there. You know, Liz, I thought maybe I'd pull you in here too. Do you think, and Sharon, you can chime in, as far as the term educator, do you think that the American Association of Diabetes Educators, what they were formerly called, changing that term kind of helps bridge that language as far as what to expect from an education? And do you think that that might be one of the barriers to getting them into education, is that it's not just education that is being provided?
That's a great question. I think these are only my views. So with the change in name, I think there's a pro and a con. I think the pro to it is focusing on the care. Diabetes education is more than purely providing knowledge about diabetes and facts. So much of diabetes education focuses on the problem solving and the coping and addressing diabetes, distress, and other emotional issues. So that's key. I do think the drawback is it's a very challenging name to remember and say. Diabetes educator was just very easy and straightforward. And I myself continue to struggle to remember the initials or to say the right words in the right order. And I think it's just going to take me another year to get it straight. And I think it's just going to be one of those things that it might take several years before providers, you know, adopt the name, or if we're just going to keep saying diabetes educator. And I know we have educators on the line, so they can also chime in if they want.
I agree with Liz. It is hard to remember. It's too long. And most people just, it's like Prince, formerly known as Prince, and whatever he changed his name to after it. You know, we're going to keep saying that for diabetes educators. But the idea was to convey these folks do more than just teach. They look at blood sugar trends. They alert primary care providers you're not taking their medicine. They do a whole lot more. And that's the whole reason why they changed it.
Okay, well, we are out of time. So I'm going to turn this back over to Jessie.
Thanks, Kathleen. Just a few quick reminders. You can watch the recordings of the current clinic on our website. For this current series, don't forget you'll need to make an account on our website, cardio.org. After you've signed up, you should receive an email where you have to activate your account. And if you're having any trouble with that, please feel free to shoot us an email. We're happy to troubleshoot. And then just a reminder, you should have the post-clinic survey in your inbox for this session. Please complete that by tomorrow at 5. And then next week's topic is type 2 diabetes in the context of cardiovascular risk. So we look forward to seeing you all then. Thanks for a great discussion today.
All right, thanks everyone. See you next week.
Bye.